Hello, the nurses of the world working hard for the patients in the hospital. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Chapter 68, Lung Disease, Pulmonary Disease of Chest X-ray, made easy for the nurses. Part 2. Let's go. Now we clearly know and understand these two images of young man on left side, young woman on right side, healthy without abnormal findings, not only airways, mediastinal margins, but also pulmonary arteries, pulmonary veins, left atrium, upper abdominal structures. Yeah, we feel comfortable with these two normal chest x-rays, right? Let's go and check out the 9 conditions, pathology cases with this session. As you all know, that doctors, especially radiologists, like to say typical findings of chest x-ray or CAT scans. Also, the pathognomic findings of the lesion. And sometimes we like to say characteristics findings of the chest x-ray and CAT scan images. These all efforts may lead us to better diagnosis and better cure, but sometimes this attitude may mislead us to wrong answers, sometimes wrong answers. So the basic role of the radiologist is differential diagnosis. Narrower the better, not the pinpoint diagnosis, but narrowing the differential diagnosis. From now on in this session, I'll show you 9 pathology conditions with relatively characteristic, relatively typical findings. Let's go first. Pneumonia, lobar pneumonia, alveolar pneumonia, and right upper lobe. Right side image is always normal young woman. Let's compare with normal young women's image with pathology condition. What's the difference? Yes, it's right upper lobe, white density, hazy density. So this is lobar distribution, alveolar density, pneumonia. Let's take a closer look. Arrows indicate black road of airway bronchus. We call it air bronchogram. And the diffuse whiteness, diffuse haziness is consolidation. So this is alveolar lobar pneumonia of consolidation and air bronchogram. Second example of left lobar alveolar pneumonia. With the first image, we don't see the retrocardiac structure of pulmonary vessels, aorta, diaphragm. That means there is a dense consolidation behind the heart because heart is in frontal location. In a closer look, magnified view, we see some airways showing air bronchograms and dense consolidation of exudate representing lobar pneumonia of left lower lobe. We still remember the terrible pandemic of COVID-19 from year 2020 to year 2022, COVID-19 pneumonia. Let's look at the left side film. The old man's condition is not so good because the film is taken as AP supine view and inspiration is not good enough. But at least we see bilateral some patch, ground glass opacity or consolidation. If we compare with the right side normal young woman's chest x-ray, it is clear, it is evident there are haziness with multiple locations. that is COVID-19 pneumonia. The old man with COVID-19 pneumonia didn't recover. His condition went from bad to worse to ARDS, Adult Respiratory Distress Syndrome. Let's look at the right side of film. The ground glass opacity became consolidation, more denser consolidation, and he got a central line and intubated. That image shows us ARDS. What do we see with this old woman's chest radiograph? At first, her heart is big, so big, too big, and there is a wiring in the sternum, post-op condition, and also we see many horizontal and oblique lines all of the peripheral lung field. Congestive heart failure, showing us pulmonary edema and cardiomegaly. This magnified view of right lower lobe CP angle area shows us what Cullis B lines are. Actually, they are interlobular septal thickening, showing us interstitial fluid, interstitial pulmonary edema. Case number 5, left side pleural effusion, dense opacity with crescent shape at the bilateral tip. We call it meniscus sign, something like nail end, and we don't see left diaphragm. That means homogeneous, dense opacity in that area. That is not from lung, that is not pneumonia, that is fluid, dense fluid. Right image is left decubitus film. As we all know, gas air of the lung is lighter than the pleural fluid in the pleural space. And also, the pleural fluid is heavier than the air gas of the lung. So, from the point of center of the Earth's globe, the gravity goes to the heavier direction. So, when in erect on left film, the pleural fluid goes down. And in left decubitus film, the pleural fluid, heavier pleural fluid goes to left side. That's pleural effusion. You subscribed and said good. Thank you very much. Grazie. Right upper lobe looks strange. Something unusual. What's that? Increased opacity with some cavities. Side-by-side view of chest X-ray and CAT scan of right upper lobe coronal view. We see 3 cm cavity with irregular whorled, thickened whorled right upper lobe bronchus, and also with 3 in-bud patterns. This is tuberculosis. We see goose egg-sized, large, big mass in right upper lobe of this old man. We call mass when the lesion is more than 3 cm, bigger than nodule. This is large mass. Large mass usually means lung cancer and right upper lobe. This is lung cancer. Lung cancer not only shows as mass, but also sometimes as obstructive pneumonitis, obstructive atelectasis of the lobe, or even the total lobe. This is the left upper lobe atelectasis blocked by squamous cell carcinoma of left upper lobe. The yellow round indicates the lung cancer, squamous cell lung cancer blocking left upper lobe bronchus. You see something or anything? I don't see anything neither. What is this? Now we see something in the yellow circle. That is Ground glass opacity, ground glass nodule. Please compare with normal left upper lobe white round. On your right side yellow circle, we see part solid ground glass nodule of 3 cm. That is ground glass nodule of adenocarcinoma. Middle-aged woman with many opacities, bilateral, many variable-sized round white densities, many lesions. What are these? Yes, hematogenous metastasis from colon cancer. She has colon cancer. This old woman's chest radiograph shows us not only many nodules, but innumerable, uncountable numbers, something like Milky Way, like micronodular densities scattered all over her both lungs. On your right side, chest thin section lung window setting CT, we see too many micronodules. We call in this condition miliary hematogenous metastasis from adenocarcinoma. Collapsed, small, dense white right lung, and the other area is all black, homogeneously black, empty space of air, filled with air in the pleural space, that is pneumothorax. We also see the gravity phenomenon here. At the bottom, we see horizontal line of fluid, and above that line are air of pneumothorax. Same pneumothorax patient with inspiration on the left, expiration film on the right. The arrow indicates the visceral pleura, the lung, collapsed lung of pneumothorax. As we see, the diagnosis of pneumothorax is easier in the expiration film, but we usually do not need expiration film. Inspiration film is good enough for diagnosis of pneumothorax if we focus on the image. This is the last topic, 10, atelectasis of left lower lobe. Now we see unusually dense, clear-margined, triangular density inside medial to heart border, posterior to heart border obscuring left hemidiaphragm and left aorta line. That is collapse of left lower lobe behind the heart. Combined atelectasis of right middle lobe and right lower lobe. This is not common. This is a rare image of collapse. When something is blocking right bronchus intermedius, white arrow indicates minor fissure of collapsed middle lobe. Black arrow indicates major fissure of right lower lobe collapse. And also we see the pleural effusion below. That is combined atelectasis. Thank you for watching. You quit smoking? Oh, what a wonderful job you did. Your sweetie smokes? Oh no, please dissuade him or her to smoke. Have a good day.